Hello and welcome to Season 2, Episode 79 of the Physician Assistant Exam Review Podcast. This week, we're going to be covering lymphomas. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review, and I am thrilled to be here with you today. I'm so excited to have you guys on board and part of the community. This last week, I launched the second edition of the Final Step. It had been 5-6 years. I think I published the first edition in 2014. I'd been updating it along the way as people found issues or they found certain mistakes. So I just been updating the file, but I never really went back and reworked the whole thing. So I had some students help me over the winter this year, and we spent 4 or 5 months reworking the Final Step and made a second edition. And the sales last week were just phenomenal. I was thrilled with how excited everybody was to get their hands on it. I'm still getting emails. I shut down sales of it, but I'm still getting emails of people asking, how can I get my hands on it? And the easiest way for you to stay informed is to be on the email list, of course. I do the podcast, so I can give you some information here. But one, I don't like to burden you with a ton of information about the website and about what I'm up to here. I know some of you feel like I do that, but really most of that information is shared through the emails. And I have a much quicker, easier way to communicate there than the once every 2 weeks that I have here on the podcast. So if you're interested in the Final Step or the Dream Job package that I offer, or the Maximizing Your Time and Efficiency package that I offer, or all the other products that I do, you're going to find those over on the website and through the email list is mainly how I share those. And there's a lot of great resources in there. Not to mention that the email list is the place where I share tips and tricks and techniques every single day of the year, or almost every day of the year, for how to pass your PANCE, get through school, and all those other great things. So that's really the best place to be in touch with me and to communicate with me and to hear what we've got going on the website and at Physician Assistant Exam Review. And you can sign up anywhere on the website. If you just head over to www.physicianassistantexamreview.com, you will find a place to sign up for the website or for the email list. It's not complicated at all. I'm sure you can figure it out. So that went really, really well. Super excited about that. Just fantastic. And I know it's going to help a lot of people. We took the number of questions up from, I think it was 1,200 on the original version up to over 2,000. So there's just a ton of questions. The book is huge. I absolutely love the way it looks. Shipping it is a bit of a challenge because it's a little bit bigger, but I just love the way it looks so much. And the digital version looks fantastic as well. So I'm excited about that, which is delivered through the Physician Assistant Exam Review app, which is also something else that's been going great. But anyway, rather than bore you with the details there, let's go ahead and get started with our discussion of lymphoma and continue on our path of hematology. Our primary question for today: name the 4 types of leukemia. So this was the last session. Name the 4 types of leukemia. Chronic lymphoid, chronic myelogenous, acute lymphoid, and acute myelogenous. What type of lymphoma are Reed-Sternberg cells associated with? What type of lymphoma are Reed-Sternberg cells associated with? Ooh, I gave you the answer to the first one. I wasn't supposed to do that. All right. That was just a review, so that's okay. I'm not going to give you this one. Are the enlarged lymph nodes in lymphoma painful or painless? Are the enlarged lymph nodes in lymphoma painful or painless? All right. So similar to our discussion of leukemia, we need sort of a broad overview for lymphoma because I've always struggled with this. I've never quite understood what lymphoma was. I never quite understood what leukemia was. I knew that they were sort of related. I knew that they were white blood cell cancers, or blood cell cancers to be more vague. And the overview, I feel like, just gets missed. Or maybe it was just in school. I was so busy, I didn't see the overview, so worried about the details. So this is going to be a time when we get a little better handle on things, a little better grasp of things. And I think I continuously say, if you don't have that 30,000-foot view, all the details in the world aren't going to stick in your brain. So I don't like to dive too deep in these discussions. I think there's plenty of places to get that detail. I think it's actually harder to get the broad overview. So that's where I like to spend my time. And I do think it helps you on exams and on tests. And retaining information for longer rather than just memorizing groups of details that will disappear very soon after your quizzes or tests. So lymphoma. Lymphoma is a group of malignancies. It is not a specific thing like the types of leukemias, or basically like leukemia. It's a group of malignancies. It is not just one type. In fact, there are over 80 types of lymphomas. That these all develop from lymphocytes. And unlike leukemia, lymphoma is a solid tumor. So leukemia was a blood-borne tumor, right? We created cells that were non-functioning for one reason or another, or would live longer than they should for one reason or another, and puts them out into the bloodstream here, or maybe in the bone marrow. But here we have actual solid tumors within the lymphatic system. Generally speaking, but understand that whenever I say that, we're not talking about always. We don't use words like always here. We don't use words like 100% of the time. Generally speaking, lymphoma develops in the lymphatic system, and the leukemia develops in the bone marrow. It's just easier to think about it that way. It's not 100%, but it's easier if you're unclear as to how to separate these two. Use that picture in your head, and it will help. Lymphoma is going to be in the lymphatic system, so there we're thinking about lymph nodes and the spleen in particular. Two main classifications of lymphoma are Hodgkin's lymphoma, which makes up about 10% of cases, and non-Hodgkin's lymphoma, which makes up about 90% of cases. And basically, non-Hodgkin's lymphoma is all of the types that are not Hodgkin's. Symptoms of lymphoma include things like enlarged, generally painless lymph nodes, drenching night sweats, loss of appetite and unexplained weight loss, pruritus, fatigue, and exhaustion. We'll start with Hodgkin lymphoma. So this is where our Reed-Sternberg cells come in. And prior to even this show, I didn't really get the whole Reed-Sternberg thing. I knew that it was associated with one of the types of leukemia or one of the types of lymphoma, but I really didn't know which one or why or what it was. So I spent a little time looking into this. And it's really not that complicated, but like everything else, if you make it more complicated in your mind than it is, you get kind of nervous and you ignore it, or at least that's what I do. Reed-Sternberg cells, these are malignant B lymphocytes. In fact, they are the malignant B lymphocyte of Hodgkin's lymphoma. They're the main factor here. They will be present. These cells have a distinct bilobe nucleus, and they appear to be multinuclear. So it looks like two cells up against each other. You can find pictures all over the internet if you type in Reed-Sternberg cell, and it might help to stand out in your mind. And once you see that picture, we talk a lot about bringing in different senses, so visualizing that may help you. The two nuclei give an owl eye appearance. An owl eye appearance. I remember hearing that term in school, but never really holding on to it. But now it makes a lot more sense. When you look at the cell, it looks kind of like a pair of owl eyes. I talk about that a lot when I talk about key terms. They come from somewhere, right? They're not just made up out of nowhere. They come from somewhere. Someone looked at this slide and said, wow, that looks like a pair of owl eyes looking back at me. And it really does. So again, you don't have to memorize owl eyes, but if it helps you to remember, then use it. It's a tool. You're not going to see the term owl eye on a test. That's not going to happen. But this is a tool to help you remember and identify a Reed-Sternberg cell. So they have this distinct bilobe nucleus, and they look like two cells kind of stuck together. Those are the malignant cells of Hodgkin lymphoma. Risk factors for Hodgkin lymphoma, these are kind of the same for Hodgkin and non-Hodgkin. So infection is one. About half the cases will also have a history of Epstein-Barr. There's some relationship there. They can have a history of infection of TB or HIV. Exposure to radiation or chemotherapy, and then in certain immunodeficiency disorders or autoimmune diseases can also carry an increased risk. I think there's some belief that the constant inflammation causes some of the problems here. And then there are some genetic factors. But a true cause is really not clear. This one is most commonly diagnosed between the ages of 15 and 40. Clinical presentation, a common presentation is with that painless lymphadenopathy, most frequently the cervical and axillary regions. Interestingly, enlarged lymph nodes may ache a little and may become painful after drinking alcohol. That can be one clue, and you may see that clue in a test question. I could totally see that. Or in the office, you may see someone who notices that, hey, I've had this lymph node for a while, and it seems like when I drink, it gets a little painful. That may be a red flag that should go off in your head. These patients can also get drenching night sweats, loss of appetite, non-explained weight loss, pruritus, fatigue and exhaustion, and splenomegaly. They can also get symptoms secondary to mass effect. So if that lymph node becomes so enlarged that it blocks the flow of what's normally functioning in your body. So you think about it like you could get, swelling in your legs if it blocks the flow of fluids back up into the body, that kind of thing. If it were in the spinal canal, you can get some neuropathies and things, right? So just that mass effect. I don't know that you're going to be able to discern that on a test, but certainly something to be aware of. You can stage these by the lymph nodes themselves and where you find this issue. So stage 1 is a single site. Stage 2 is 2 or more lymph nodes on the same side of the diaphragm, or one extra lymphatic site and one lymph node on the same side of the diaphragm. Stage 3 is affected lymph nodes on both sides of the diaphragm or involvement with the spleen or another extra lymphatic site. Stage 4 is diffuse extra lymphatic involvement. Labs and studies. So lymph node biopsy showing a Reed-Sternberg cell is necessary for diagnosis. So that's our key right here. Again, when you think Hodgkin's lymphoma, you should think Reed-Sternberg cells. That should be just pasted together in your brain. The chest x-ray may show mediastinal lymphadenopathy. And if it does, or if you're looking for this, you're going to want to get a CAT scan of the chest, neck, abdomen, and pelvis, and a PET scan. You may also wind up getting a bone marrow biopsy. Now, you're also going to do, that's kind of a focus workup, right? Of course, you're going to do a CBC. You're going to probably do liver function tests. You're probably going to do all of these things, kidney function tests, all of these things. But I've sort of just narrowed it down a little here for you. Treatment, again, is going to be a little bit complicated, but for our purposes, it's combination chemotherapy, radiation therapy, and stem cell transplant. Non-Hodgkin's lymphoma is our other type here. We're going to talk about, this is a category of blood cancers that includes everything, all of the lymphomas that are not Hodgkin's lymphoma. Sorry, I'm stumbling through that because I wrote it kind of funny in my notes. There are so many subtypes here that I'm going to give an overview, but you're not going to get specifics, right? You're not going to get exact symptoms and treatments and things because it's very, very specific as you move down the chain. These are far more common than Hodgkin's lymphoma, like we talked about. This makes up about 90% of lymphomas. And these are still mostly malignant B cells, just not the Reed-Sternberg cells. It just depends on where and when that mutation happens, where or when that issue happens as these cells are differentiating, produces the different types of lymphoma. Just like we talked about last week with leukemia. This disease is generally widespread at diagnosis. Your risk factors here are very similar to what we just talked about for Hodgkin's lymphoma, which is infection, Epstein-Barr, TB, HIV, or Hep C, exposure to radiation or chemotherapy, and then certain immunodeficiency disorders or autoimmune diseases carry an increased risk. Our presentation here, again, is painless peripheral lymphadenopathy. These may form large masses and again leading to compression of nearby tissue. Patients here can have drenching night sweats, loss of appetite, non-explained weight loss, pruritus, fatigue, and exhaustion. So again, similar symptoms. Just like with leukemia, these aren't easy to separate, right? There's not so simple. We use cell markers and things to separate them, not really physical diagnosis. Lab studies and physical exam findings. You're going to do a CBC, which may show anemia. A chest x-ray may show mediastinal adenopathy. A bone marrow biopsy, CAT scan, and a PET scan. And then again, and then again, a lymph node biopsy is how you're really going to diagnose this. The rest is going to be for staging and for setting up treatments. Staging here is pretty much the same as it was for Hodgkin's lymphoma, which is stage 1 is a single site. Stage 2 is 2 or more lymph nodes on the same side of the diaphragm. Stage 3, affected lymph nodes on both sides of the diaphragm or involvement with the spleen or another extralymphatic site. Stage 4 is diffuse extralymphatic involvement. Treatment here is going to be combination chemotherapy and radiation therapy. So for me, the real question is, how do you discern Hodgkin's from non-Hodgkin's lymphoma? Right? If you're writing test questions, how are you going to write these test questions? Well, you're going to have something about leukemia, and you're going to have something about lymphoma, and you're going to include some overlap between leukemia and lymphoma and ask people to separate the two. At least that's what I would do. So I'm not talking about necessarily in your office setting, but in a test setting. How would you separate these two? What information did we cover that would allow you to differentiate these two in a simple vignette? Well, the number one is Reed-Sternberg cells, right? That's going to be the easiest way. So if you get this binucleated cell on a slide, then it's easy. Then they're handing it to you, hopefully. Not to me in my first several go-arounds, but on the next test I take, they'll be handing it to me because I'll know that one. Another way to separate them is that Hodgkin's tends to be a contiguous development, meaning that it goes from one lymph node to another in a direct line, whereas non-Hodgkin's tends to be more disseminated progression. Another is that the symptoms of what they call B symptoms, so the symptoms of like night sweats and fatigue and weight loss, tend to be more common in Hodgkin's disease early on. And then another factor is that although we talked about Epstein-Barr and HIV for both, Epstein-Barr is a little bit more related to Hodgkin's, and HIV is a little bit more related to non-Hodgkin's. So again, these aren't great clues to separate it, but that's all you've got. Of course, I'm willing to be corrected. If anybody has more, I would happily update the information I've got here. If you could write a test question that would separate those more clearly. Our last one for today is our last part of this is multiple myeloma. This is a cancer of the antibody creating plasma cell. Remember, plasma cells are differentiated from B cells also. So it's all in the same line, right? It just depends on when that mutation happens to that particular cell. So in this case, there's a buildup of plasma cells in the bone marrow interfering with the production of normal blood cells. So we're going to have these patients wind up with some anemia as well. Risk factors. Obesity plays a role here and increases risk. Radiation exposure, chemical exposure, and then again, we get the infection with Epstein-Barr or HIV. This most commonly affects people over 40 years old. Clinical presentation here. Symptoms are secondary to poor cell production in the bone marrow and the overproduction of non-functioning antibody-like protein. Let me say that again. You have these plasma cells that are being overproduced. So now we're not making normal cells, just like we talked about with leukemia. So we wind up with anemia. Then not only do these abnormal cells, these malignant cells, take over cell production, but they also then produce their own materials, right? They create these non-functioning antibodies, these proteins, and they dump them out into the bloodstream. Some of the things that they do is that these malignant plasma cells release hormones into the bloodstream that increase osteoclast activity and suppress osteoblast activity. So they start chewing away at the bones. And that's where the bone pain comes in from multiple myeloma. Bone pain in somebody over 40 or 50 should ring some bells and cause some red flags, whether in your office or on a test question. These patients will also have symptoms of anemia. If you can imagine what happens if you have haywire plasma cells shooting out antibodies that don't work all over the place, what happens to your immune system? It's obviously not going to be functioning as well. So you have a poor immune response and infections go up. These patients often also have renal failure. Can you imagine why? I'm just sitting here thinking as I did that last week, we took my kids to go see Ferris Bueller's Day Off in the local theater. And all I can picture is, as I'm saying, can anyone see why? Can anyone? If you haven't seen the movie, it came out in 1986, and I highly recommend it. Anyway, why do they think they would have renal failure? They'd have renal failure because of those excessive paraproteins. They overwhelm the kidney with these proteins in the bloodstream. They also wind up with hypercalcemia, which may lead to kidney stones. Why do they wind up with hypercalcemia? Because those osteoclasts are destroying the bone. That extra calcium gets dumped out into the bloodstream. These patients will also present with weakness, fatigue, and then some mental issues like confusion, and then progressively getting worse and worse. Labs and studies. These patients are going to get a skeletal survey, which is an X-ray, X-rays of the axial skeleton, X-rays of the skull, and I think of the long bones. I'm not 100% sure. These, what you're looking for are punched out lesions. That's the key term here. These are little holes all through the bone. And this is, again, because those malignant plasma cells release those hormones that increase osteoclast activity and suppress osteoblast activity. So you get these lytic lesions, these little tiny punched out lesions in the skull and on the other areas. So you're going to be looking specifically for those. You want to get an MRI and a CAT scan. Obviously, you're going to get a bone marrow biopsy. You can measure circulating IgA, IgG, and IgM. Urine specimens may contain monoclonal proteins. Serum specimens containing monoclonal proteins. Patients, again, may have hypercalcemia. We talked about that a second ago. And they'll have a normocytic, normochromic anemia. Treatments. If there are no symptoms and no end organ damage, there is no treatment. After that, we talk about chemotherapy and stem cell transplant. Our 5-year survival rate is somewhere about 35 to 40% for multiple myeloma. So you can see why these get grouped together, right? They all sort of come from a B cell line, lymphomas. And if you can go back to that image I had in the last show for leukemia, you can follow the development of the blood cells and get a better idea. Just consider it's where on that path does a mutation or a problem occur that causes a cell to become malignant, and then that cell reproduces and creates more and more of itself. So it just depends on which type of cell and when it occurs that we get these different classifications of diseases, and then we treat them differently, right? So that all kind of starts to make some sense once you look at some of those charts and have a good idea in your head, and you can start to see the difference between leukemia and lymphoma and see how you can separate these things out. Again, both on your test questions, but also in your practice. All right, let's talk about a study tip for today. I was talking with a student yesterday, or actually not a student anymore. She passed her exam. I've been interviewing people for a series I'm calling post-game interviews for people who have passed the PANCE or taken the PANCE and just want to share their experience with people who are getting ready to, right, are a little nervous and a little anxious. So we talk about things like how you prepare, how you get ready, what made you comfortable, what made you uncomfortable, what would you have done differently, those sorts of things. And this individual is talking about a practice that I definitely subscribe to and I definitely recommend, which is driving to the site of your test before the day of your test, right? Because the goal is on the day of your test, you're going to be super anxious. Your brain's going to be cranking. You're going to be nervous. You're going to be working really hard to hold it together, right? I tend to be a pretty calm person. I tend to be a good test taker. And I went and took my second PAN-RE, and your heart's beating at, what normal for me is about 55. And it's probably, I didn't have my watch on that day, but probably about 120, I'm sure, when I walk through the door. It's a tough day, right? So you want to make things as easy as possible. One way you can do that is being confident you know where you're going. You want to recognize some sites along the way. You want to recognize some landmarks along the way. It just makes it easier, makes it more comfortable. I know you have your GPS. I know you trust it, but it still makes it easier. Sometimes when you get in the building, it's a little hard to find the exact office. I know once or twice I've walked in circles for 15 minutes trying to figure out where exactly the area I was supposed to be taking my test in was. So there's two parts to this. One is I absolutely recommend that you do that drive over before the day of your exam. But the interesting thing, I don't know why, I never thought about this before, and it makes so much sense when we were talking. There's no reason to do that drive the day before your test. You can do that the day you sign up. you know the location. So you can do it 2, 3, 4 days, a week before, when you get a break, when you have a little downtime, or you want to kill some time and you want to give yourself a mental break. Take a drive over, even if it's an hour away. Put the radio on and drive on over. And like I said, it never occurred to me. I always thought I would do it the day before the test. But then I think the last time I took my PANCE, I was like, I got to the day before and I was like, I don't really feel like it. I don't really need to do that. And then as I'm driving there, it was about 45 minutes away in an area I don't go to, in a direction I don't normally travel. I did get a little nervous, or it just takes a little extra energy. Well, why not have done it a week before, 2 weeks before? That to me makes a ton of sense. And then you really have no excuse and no reason not to. I just think it makes a lot of sense. So our tip for today is not just prepare for your test, but do it early. Pack your bag of snacks, pack the things you're going to want to take with you. Pack that early. Don't do it the day before. Do it a week before. That way it's done. You don't have to worry about it. Anyway, that's our study tip for today. Let's move on to answering our pre-questions. Name the 4 types of leukemia. I know I gave you the answer at the beginning. Let's see if you can still retain it. Name the 4 types of leukemia. Chronic lymphoid, chronic myelogenous, acute lymphoid, and acute myelogenous. What type of lymphoma are Reed-Sternberg cells associated with? Please know this. What type of lymphoma are Reed-Sternberg cells associated with? Hodgkin lymphoma. Are the enlarged lymph nodes in lymphoma painful or painless? Mostly painless. Do you remember the time I mentioned that they might not be? It was with Hodgkin with ingestion of alcohol. One more time. What type of lymphoma are Reed-Sternberg cells associated with? I really need you to understand, to get this one and drive it home and have it stick in your brain. Reed-Sternberg cells are associated with Hodgkin lymphoma. All right. So that is all for today. Like I said, these are big topics that are just difficult, hard to get through, hard to separate out, hard to keep from jumbling into a big mess in your brain. That's what I always found. I could learn them, but then I would turn around the next day and it would just be a big mess of things that I just couldn't quite get a grasp on. And I think there's some low-hanging fruit here that you're going to be able to get right on your test. Like I said, the Reed-Sternberg cells for sure, and just separating out some of this stuff is not going to be that hard. Don't necessarily need to dive into tons of detail. We don't need to get to all the subtypes, the 80 different subtypes of lymphoma. I don't think that's necessary. But on the surface level, certainly, I think you can do better than I did. Let's just put it that way, by knowing a little bit, knowing the low-hanging fruit in this section. So that'll be it for today. Just want to say take care. Thank you to everyone who's been leaving reviews in iTunes. That's really helpful. It really helps keep me going. The emails do the same. And I cannot wait to talk to you again in 2 weeks. I think we should be just about finishing up hematology. Can't wait for that. All right, take care.